This is where we go into the trial that you've worked on. So, GoFresh wasn't just about testing whether the DASH diet works. It was about making DASH style eating accessible to these populations that has historically been left out of such interventions and evaluating whether a delivery plus counseling model can realistically be part of hypertension prevention and health equity strategies. So, can you walk us through the design of GoFresh? Who was enrolled? What was the intervention? Exactly what did it entail? And what made this approach different from the traditional lifestyle programs?
Yeah, absolutely. So as I mentioned, there had been great evidence around DASH eating and low sodium diets for reducing blood pressure and improving cholesterol. However, these trials, so DASH and DASH sodium specifically, published in 1997 and 2001, were conducted in a metabolic kitchen setting. Where all of the different micronutrients and macronutrients were tightly controlled, and the diets were actually created by chefs and by dietitians in these academic institutions to achieve the dietary contrasts under study. They showed remarkable benefits from adopting a dietary pattern like DASH on blood pressure and on LDL cholesterol. And really, this formed the foundation for a lot of what we know about healthy eating for cardiometabolic health. However, not only were those meals prepared at a time that's now about several decades old. So some of those products are no longer around, and how people are eating culturally has changed. But also they were somewhat artificially created. The investigators very thoughtfully tried to use foods that people could and would eat based on like an American style of eating. But still there was some artificialness to it, right? You couldn't necessarily go and buy those meals at your grocery store. And I think another important thing to recognize is that the United States is increasingly multicultural. And even with DASH being intentionally a diverse cohort for testing their American style healthy diet, there still will be a lot of differences across cultures, even at the individual family level. And so we wanted to examine a more real world implementation of DASH. So we focused on groceries with this idea that if we took DASH principles but went to the grocery level, anybody could choose and create their own version of DASH that they could enjoy and their families could enjoy with them, right? And so we would get away from, well, this is the American version of the diet, this is that version of the diet, that version of the diet, which is really endless because even within my own family, we have such strong differences in terms of what people like to eat, right? So it's
True.
not, it goes
Preferences.
preferences are so strong, right? And so we wanted to get down to the family level. We wanted to get down to groceries, which are the building blocks of meals, so that people could really customize DASH for them in a way that they would want to continue eating it. And we focused on Black adults because the effects of DASH were stronger in those two feeding studies that I described. So they had Black adults had larger reductions in blood pressure from the healthy diet. And there are a lot of potential hypothesized reasons for this. Some have to do with ancestry. There's some thought that lower potassium intake at baseline could also be a factor for larger effects. But we felt like this was a group that, at least mechanistically, would definitely benefit from a low sodium DASH pattern of eating. We wanted to address the health equity concern. So we focused on Black families that lived in Boston area zip codes that had been defined as food deserts or healthy food priority areas. So regions where there were fewer grocery stores that had fresh produce and healthy foods. And there were communities that were characterized by a lower median income. So we wanted to focus on these communities. And then a big feature of what we did was we wanted to show that access to the DASH pattern groceries could impact blood pressure specifically, and secondarily LDL cholesterol and other cardiometabolic health risk factors. And so a big part of our focus was on working with virtual grocery stores to deliver groceries that were chosen by participants for themselves and their families and then delivered to people's homes in these regions to demonstrate that not only what principles of healthy eating were effective for lowering blood pressure and improving cardiometabolic health, but also to show that or to test that access to these groceries can make a difference. And so the design of the study, it was a multi-phase study where we took 180 individuals that self-identified as Black or African American, and half were assigned to a self-directed a grocery shopping group where they got a $500 stipend every month over 3 months. During the active intervention phase of the study. And then the other half were assigned the DASH grocery intervention, which entailed weekly sessions with a dietitian where they got a brief didactic about healthy principles of eating, where they worked together to order groceries following DASH principles, and where they reviewed what was consumed last week to see if they could customize a little bit more and improve over time. That would happen, those sessions happened over a 12-week period. So they had 12 sessions. And people had blood pressure and labs performed before the intervention phase and after the intervention phase. After getting their post-intervention labs and blood pressure assessments performed, participants entered into a maintenance phase of the study. During this phase, we pulled back. There was no more stipends provided, no more groceries or counseling sessions provided, minimal contact. Folks were allowed to apply what they had learned during the prior active phase over a maintenance period. And then after an additional 3 months, folks were invited back for a repeat assessment of blood pressure and of labs. And the goal of that phase was to observe whether or not the health benefits of the first 3 months were sustained over the following 3-month period.
Wow, this is great. I love all the aspects of the study. I love how it wasn't like one size fits all. We give you the ingredients of a DASH diet and you do with it in your kitchen what you want to do that relates to you, your culture, your family, and how, what your food preferences are. This is great. And I think I have one question on during those 3 months of like maintenance, as you said, were they also receiving delivery like groceries or were they
No,
left on? Okay.
yeah, folks were left on their own. And so they had the knowledge of, they were given their 12 weeks of groceries. So they had the knowledge of what they had been ordering and what had worked for them and their families. They had some recipes for applying DASH principles in new ways with new groceries and some of the didactic information that had been conveyed by the dietitians, but they no longer got the provision of groceries. And we provided the average amount of groceries that were provided. The median value was about $240 per family per week. When we asked people at baseline how much they were spending on groceries for their family, the average amount was about $190 per family per week. And so it was a little bit more than what people had been spending at baseline before randomization. And so that kind of support was removed during the maintenance phase. And we wanted to see how important the provision of the groceries or the stipend were in order to achieve the health benefits, and then what things looked like when that was removed. So.
Okay. Yeah, very interesting. You said that there were some dietary guidance or coaching. So what specific dietary guidance or coaching did participants really receive? And how was it tailored for individuals with limited access to healthy foods? As you said, there were some areas where they didn't really have direct access to these healthy foods. So how did you go about that?
Yeah, so we worked with some local grocery stores. We worked with Amazon Fresh and Whole Foods. We also worked with Instacart. And so we had, in Boston, the Black community was quite diverse. And so we had participants in our study that were born in Africa, participants that were born in the Caribbean, and participants that were born in the United States. And everyone had different family situations. We had some younger single family sort of student age participants. We had some smaller family, older adults that maybe had osteoarthritis and so had some concerns about meal prep. It wasn't as easy to chop, carrots, for example. We had some folks that would celebrate different religious holidays like Ramadan. We had some vegetarians in the study. So we tried to meet people where they're at and partner with them. We emphasized four principles for the grocery orders. The first was to cook and prepare meals at home and to season without salt, using other herbs and seasonings that did not have sodium in them. The second principle was that the grocery list should have twice as much potassium as sodium. And so we tried to maintain an overall ratio of 2 to 1. And we used an ordering sheet with their dietitian to help facilitate that. And they would recommend substitutions to try to get to that goal. The third principle is that the total amount of or proportion of calories from saturated fat would be less than 7%, which was a feature of the DASH diet. And the fourth principle was that the distribution of groceries would model a DASH pattern of eating. And so that meant about a third of the groceries would be fall into the category of fruits and vegetables. About a fifth of the groceries were whole grains. And then about 15% would be lean meats. And then about 10 to 12% would be low-fat, fat-free dairy, and then 8% nuts, seeds, and legumes. And so that's how we kind of try to have the distribution of groceries be patterned to mirror a DASH diet. The dietitians provided initially some brief didactics about reading nutrition facts, about sodium, potassium, about we called it smart shopping, or ways to get the most bang for your buck. We also had some optional modules related to how do you follow DASH in a special occasion or with the holidays. And then we increasingly became more tailored to individual needs. So it became a lot more interactive. We asked people to say, bring your favorite recipe and let's adapt it to make it more DASH compliant so you can continue to enjoy that with your family. We worked to create individual meal plans with people for their families. We enrolled up to, you could have up to 6 adults at dinner time in your family. So we tried to make it, we had some financial restriction because we were paying for all the groceries, but we tried to allow for a lot of different family types. So we had families with children, with teenagers, with several generations. But the idea was that we could partner with them for them to have their version of DASH.
Okay, amazing. Very nice. So, how did the GoFresh intervention, though, fit alongside other pharmacological hypertension care? So, you said they had other comorbidities. You mentioned arthritis and some physical restraints and so on. But I'm sure they were the participants were at different stages of hypertension, and some of them might have been on taking some blood pressure medication. So, how did that fit alongside with the trial?
Yeah, so that's a great question. So the trial did have some restrictions in eligibility criterion.
Mm.
We did not allow folks with diabetes to be in the study. We did not permit folks with advanced stage kidney disease, so stage 4 or 5, to be in the study. Part of that was related to DASH being a little bit emphasizing carbohydrates, and then also our emphasis on potassium.
Potassium.
For this particular trial, we excluded individuals who are treated for hypertension. Now, that being said, I completely agree with you. We think this population with treated hypertension is incredibly important. And so we have a trial that we're just finishing up right now called GoFresh RX. And that cohort enrolled 176 adults and is focused exclusively on Black adults with treated hypertension. And so we'll be hopefully sharing those results in the coming months. We're really excited about that study as well. And so, so there were some restrictions, but for the most part, we did try to be open to most folks in the study. The blood pressure range for those included was 120 to less than 150 millimeters of mercury systolic, and a diastolic blood pressure less than 100 millimeters of mercury. The reason we restricted to this range was we were focusing on prevention in our population. And so we didn't feel comfortable if the systolic blood pressure was too high. We felt like for those individuals, we'd want to start treatment consistent with the recent guidelines. And so that was our approach initially. But we are excited about this other study that will allow us to probe a little bit more severe versions of hypertension.
Okay, nice. And were there any clinicians involved? Were clinicians part of the intervention, or did it run parallel to usual care?
Yeah, so for the self-directed group, certainly they were provided a brief um, a handout on DASH eating and a stipend, but they were ultimately self-directed in terms of their choices of groceries and then the rest of their care. We did ask that everyone in the study have access to some form of primary care in the event there was a high potassium value or some lab that needed more urgent follow-up, or really high blood pressures that we felt like needed, especially during follow-up, needed some attention. This didn't happen all that often, fortunately,
Mhm.
but we did have clinicians as part of our study team, myself included. We also had a nurse practitioner, and we would review labs in a timely way and try to reach out with any health concerns that would arise during the study. Again, for our study, there wasn't a lot of health concerns because our intervention was somewhat minimal risk, but that was some of the oversight that we provided as part of this trial.
Well, I'm excited to know about what happened. So,
Yeah.
what were the major findings in terms of blood pressure control, diet quality, or cardiometabolic markers? Because you did mention that, you were able to also look at the lipid profile and other factors that could go into, cardio health. So,
Absolutely. Yeah, we were really excited to see those results as well. So what we found is that among the grocery group, during the active intervention phase, there was a net reduction in systolic blood pressure of 5.7 millimeters of mercury. While among the self-directed group, there was also a reduction in systolic blood pressure of about 2.3 millimeters of mercury. And so then when you compared the two, the net reduction was 3.4 millimeters of mercury systolic blood pressure. Similarly, for diastolic blood pressure, there was a net reduction of 2.2 millimeters of mercury. And then we also observed during the active phase a reduction in LDL cholesterol of 8 milligrams per deciliter. The intervention was designed to be isocaloric, so we adjusted the amount and provision of groceries to meet individuals' complete caloric needs. So we were trying to replace their whole diet with a healthy diet, healthy groceries, but not to be weight changing in any way. So there was no net change on weight. We were happy about that because it showed that the diets were impacting health independent of weight loss. We thought that that was an important thing to demonstrate. There was also no impact on hemoglobin A1C. Again, that wasn't a target of the study. We were more concerned by reports of prior grocery intervention studies that showed an increase in blood sugar as a result of the grocery intervention, in part because some potassium-containing foods can be higher in carbohydrates. We did not observe that at all, so there was no net negative effect on glycemia. We were very happy about that. Um, and and we also looked at a 24-hour ambulatory blood pressure monitoring, and we found similar wait time reductions in systolic and diastolic blood pressure that were very much in line with what we observed with our main primary office assessment. And then there was also a reduction in urine sodium concentration, suggesting that at least in line with the intervention, people were able to reduce their sodium intake as a result of the intervention. So all of it was very, very positive. Their self-reported DASH score also increased. However, when we went to the maintenance phase, and so the provision of groceries was removed, the stipend was removed, what we found is that some of the majority of these health benefits kind of went back to where the self-directed group had been, such that there was no real maintenance of the difference between the two groups at 6 months. We thought that this was important information. While we would have liked the intervention, the health benefits to be perpetuated, we did not resolve the underlying barriers in social determinants that we believe are contributing to some of the higher blood pressures to begin with, right? We didn't build grocery stores. We didn't create an affordable, accessible way for people to continue the diet. They may have had the knowledge, they may have had the what, right, the list of groceries to order, but the how and the means to do that weren't necessarily addressed by the study. And I think that this really confirmed to us not only the value of these principles for achieving health benefits, but also the importance of addressing the underlying barriers for maintenance longer term.
Hmm. Okay. Yeah, absolutely. I do want to go back a little bit to if there were any secondary outcomes from the study. I know you mentioned there was no weight change or any other, changes in the glycemic index or anything of that sort. But what were there any secondary outcomes that stood out to you?
Yeah, the LDL cholesterol reduction of 8 milligrams per deciliter as a result of the intervention, I think was quite impressive. When you look at Predimed, for example, the LDL cholesterol reduction was about 5 to 6 milligrams per deciliter at 3 months. So we actually had a bigger reduction in LDL cholesterol than even Predimed, which we know reduced cardiovascular disease events. So we felt like that was very encouraging. I mean, again, we didn't give the same thing to any single person. So this was just using the DASH principles to construct unique diets for each individual. But yet, in aggregate, we were able to achieve these kind of LDL cholesterol effects that were quite strong. As a comparison, dash sodium, the LDL cholesterol reduction was about 12 milligrams per deciliter. So that's in a very tightly controlled setting. So we felt like to get 8 was quite good and quite encouraging, and suggests that in addition to blood pressure reduction, which was our primary endpoint, we could also achieve other benefits in cardiometabolic health, which are quite relevant to preventing cardiovascular disease.
Absolutely. I love this. I love that it was, up to them, the participants, to create whatever they want with the groceries that you provided. And this ended up with good, positive cardiovascular kind of benefits, not only for their blood pressure, but also on the lipid profile. So this is great.